Medicine, but I chair the Emergency Medical Services and Disaster Management under the Philippine College of Emergency Medicine, or PSEM. Okay, thank you for inviting me and allowing me to discuss about Hospital Incident Command System and introducing what the One Hospital Command Center is under the Department of Health. Can the Secretariat share the slides? Thank you. Okay, are we already sharing the slide? Yeah, can anyone confirm to me if the slides are already being shown? Because on my side, it's only black. Thank you.
For a while, Doc, we are having technical difficulties at the moment.
Okay, no problem. Yeah. Probably I'll start my lecture while they are fixing the technical difficulties. So as mentioned by Jam, was it Jam? I'm now with the National Patient Navigation and Referral Center, if you're quite familiar with it. So it's under the Department of Health. It is one of the response of the government in response to COVID, or in COVID-19. Okay, so let's start. So it's a pleasant morning to everyone again. It is my honor and pride to present the National Patient Navigation and Referral Center, or previously known as the One Hospital Command Center, and its endeavor to provide optimum service delivery to quality, equitable, and accessible healthcare services that support the provision of the Universal Healthcare, or the UHC Act. It has been a whirlwind of challenges, but despite the difficulties, we opt to move forward with the heart fueled with passion to serve the Filipinos. As we all know, no one was ready for a pandemic. We never knew that we will experience COVID-19 in our lifetime. Okay, going to the next slide. Okay. Just to read some of the objectives that was set by the organizer, we will be describing the contents of the Hospital Emergency Operation Plan. Next is enumerate the components of the Hospital Incident Command System, or the HICS. Discuss the structure and function of the HICS. And lastly, to introduce the National Patient Navigation and Referral Center. And you may look into it as one of the ICS, as a component of the ICS under the Department of Health. Whenever we going to the next slide. Okay, whenever we discuss ICS, or Hospital Incident Command System, we always discuss this four phase of emergency management. The first, there are four phases. Okay, mitigation, preparedness, response phase, and also recovery. Okay, so during the mitigation phase, this is the most cost-effective method for reducing the impact of hazard. A precursor activity to mitigation is the identification of risk. Physical risk assessment refers to the process of identifying and evaluating the hazard, and the higher the risk, the more urgent the need is to target hazard-specific vulnerability through mitigation effort. But with the experience of pandemic, no, and again, nobody knows that we will experience pandemic. So although we have risk assessment on the infectious, but we never knew that COVID will be this big and eventually turned out to be a pandemic. Okay. Next phase would be the preparedness phase. This is a continuous cycle of planning, organizing, training, and equipping, exercising, and evaluating and improvement activities to ensure effective coordination and enhancement of capabilities to prevent, protect against, and respond to, recover from, and mitigate against disaster event that have been identified within the hazard vulnerability analysis or HVA. So one of the things that we have been doing under East Avenue Medical Center and also with the Philippine College of Emergency Medicine is to train people. I can still remember during 2019 together with the toxicology unit of the East Avenue Medical Center, we trained pre-hospital provider on how to don and doff or properly don and doff a PPE. This preparation is with handling of chemical events, but we never knew that we will be using that training in handling pandemic or in handling COVID-19 patient because it's somehow similar on how to don and doff properly your personal protective equipments or your PPEs. So those are one of the things. Next thing are um, training the continuous training of the nurses and doctors or even the pre-hospital providers, the EMTs on basic life support, on advanced cardiac life support, and even handling of specimens. So we've been training those healthcare workers. Okay. Now, going to the third phase, which is the response phase, this includes the mobilization of the identified emergency staff, including the first responder to an internal external event, which could have an impact of patient care operation on or the campus. So response procedure are predetermined by the hospital and are detailed in disaster plan during the preparedness phase. Okay. Just to share to you our experience at East Avenue Medical Center when we started dealing with COVID patient. Of course, all the plans, even though we have initial plans, but we didn't know that it will become big, so we have to revise our plan. Okay, so starting with just one emergency department, we transferred to an alternate emergency department and eventually put up some tent outside the hospital and eventually transferred to another building to be a COVID-19 specific um, facility just to cater COVID-19. Okay. The last phase would be mitigation, or this aim or the recovery, or I mean the recovery phase. Sorry. So the aim of the recovery phase is to restore the affected area to its previous state. It differs from the response phase in its focus. So recovery efforts are concerned with issues and decisions that must be made after immediate needs are addressed. Recovery efforts are primarily concerned with action that involve rebuilding destroyed property, re-employment, and repair of other essential infrastructure, as well as the reopening of essential services in the hospital. That's the problem. That's one of the problem that we are handling in this pandemic. So during the last 2 years, we are focusing more on the pandemic or COVID-19, and we forgot other illnesses. That's why currently in the National Patient Navigation and Referral Center, we've been receiving calls of non-COVID cases, non-COVID related cases, because um, they've been they've been delayed of the treatment that they need, especially yung mga cancer patient or as simple as patient with hypertension or even diabetes, for example. So these are the four phases. Again, these are the four phases of emergency management. So we have mitigation, preparedness, response phase, and recovery phase. So right now, hopefully, tuloy-tuloy na yung ating recovery phase. So we're shifting now to an endemic phase. Okay. Let's go to the next slide. Next slide, please. All right, thank you. Since the healthcare system itself forms part of the any crisis response, the administrator of healthcare facilities and hospital must formulate a comprehensive disaster plan detailing their organization's intended course of action in the case of any kind of catastrophe. The complexity of ensuring continuity of services through the myriad disaster can occur puts hospital at the forefront of emergency planning. That's one unique thing in the health services or inside the hospital in particular. You will not stop your usual services, but you just need to have a plan in responding to an emergency, just like COVID. So inside of any emergency department or inside any hospital, they have COVID and non-COVID cases. So they need to respond on both cases. Okay. So hospital emergency operation plans covers all hazard. So in general, when you do your emergency operation plan, it should cover all hazard. So again, we never knew that pandemic will be coming. So most of us were caught on surprise and doesn't have a more detailed plan on the pandemic. So when during our experiences in the pandemic or responding to COVID-19, we keep on adjusting depending on the researches or new discoveries of COVID-19. Okay, so the first element that we will discuss is communication. So hospital rely on efficient communication even in non-emergency. We all know what's the importance of communication. During a crisis, the execution of an emergency operation plan or your EOP can hinge on communication because we need to relate to all individuals involved in the emergency operations the direction of the incident command or the direction of the plan. Okay, an effective disaster response will involve communication with other local first responders. So networking is also very important in coordinating with other health facilities or even the local government. The next key element is resources and assets. If an organization intends to be operational throughout an emergency, it needs to identify from where it expects to acquire and restore its stocks of non-medical supplies such as food, water, and clean beddings. So remember, no, during the first few months of the first few months of our response to the pandemic, we had problem in our resources. Like for example, um, yung ating mga PPEs, or even to the point that sobrang init at that time. We started on a very warm weather at that time. So yung mga frontliners natin were asking for even water and food supply to the government. And because of the bayanihan spirit, madaming nag-donate sa mga hospitals natin or to our frontliners. Okay, so those are things that we have to think about during any emergency. And for pandemic, it's important that we need to provide PPEs to our frontliners or to our hospital, not only to the doctors and nurses but also to the medtechs and to other allied healthcare providers, because inside the hospital, it's a system that is working. Hindi pwedeng isa lang yung bibigyan mo ng supply and the rest will not be given any other resources. Okay? So during the pandemic, we really had problem from the start because wala pa tayong enough supply. Even the government cannot provide. There have been planning with the other facilities, like for example private institution, that they've been sharing also their resources, so that the government can also respond to the pandemic and help out um, in the referrals and management of COVID-19. Okay. That next element is safety and security. This is one important thing that we need to consider during any emergency. So even in our usual operation, everyday norms, it's really important to make sure that the safety and security of all the staff and personnel inside the hospital. Okay. The administrator must evaluate the potentially safety and security hazard that may arise in any given disaster and document their mitigation plan. So for COVID-19, we make sure of we study about the latest guidelines on how to make how to make the environment safe. So during the time there was a guidelines on having a air purifier inside the emergency department or inside any other offices. So nag-purchase tayo ng mga equipments how to make the environment safe. Next would be staff responsibility. So the fourth one is staff responsibility. The roles and responsibility for staff and licensed independent contractor or yung mga job orders natin must be clearly established and understood if an emergency operation plan is to be effective. One good way of doing this is to have a job description for every personnel na ma-encounter natin inside the incident command system. So what we usually do when we activate an incident command system, they have their job order or they have their job description. Remember, sometimes they wear a vest, no? Yung during an emergency, they have the vest. Included there in the vest, aside from the ID, they have their job description. So kung ikaw ay, let's say, operations head, so you just have this list of job or roles and responsibility that you need to accomplish, so you will not get into loss. So if you need, it will place there that you need to report to the incident commander every now and then, or you need to communicate with the logistic officer every now and then. So para hindi loss yung mga tao, you need to write those roles and responsibilities. The next key element, the fifth one, is utility. So the hospital emergency operation plan should also document the essential utilities required for the smooth functioning of the organization. This can include water, electricity, telecommunication, fuel, ventilation, medical gas, and vacuum system. So remember, during the pandemic, we have to restructure the hospital. We don't have enough space for infectious diseases. Honestly speaking, we don't have enough space. That's why we need to restructure. We need to restructure the hospital ward, the rooms, or even the emergency department. Of course, when you restructure it, that includes your electrical supply, your communications, and even your water supply. That's why we need to have portable na mga water supply, and then eventually we transferred into may mga portalets na rin tayo na dumadating inside that complex, the COVID-19 complex. So that's how difficult handling COVID-19 is. Lastly would be the clinical and support activities. So meeting with the clinical needs of patient remains the highest priority for a healthcare organization, even during an emergency. Thus, a hospital emergency operation plan needs to document how clinical and support activities will be maintained. Again, we never know during the start, no, how to deal with COVID-19. That's why DOH and also one of the things that PCM was doing at the start of at the start of the response of COVID-19, we keep on training people. We train our residents, we train pre-hospital providers on how to deal COVID-19 so that they'll be confident on handling cases like that. Okay, let's go to the next slide. So after discussing all of those, the emergency management, and also the six key elements, and hospital emergency operation plan should or could include the following that are indicated written in the slide. So you need to have a plan implementation, notification of emergency phone system, and when and how to activate your emergency phone system, even handling of media, resource procurement, it should all be written in your emergency operation plan, because this is not a normal activity. So we have a normal procurement activity, but however, during a pandemic or during any emergency, we need to have a plan on emergency procurement. Okay, so an emergency operation plan should also include acute care site establishment, crisis staffing, and also shelter availability, and even care of the deceased. Okay. Remember, during the pandemic, there's a lot of mortality. I remember in East Avenue Medical Center, medyo na news pa nga to, no, na sabi na sa floor na daw yung mga body ng mga patient, but it's not true. We have a small morgue inside the hospital. However, because of, again, bayanihan, some NGO gave us a ref van. So this is a refurbished na mga van, no, yung mga lagayan ng mga chicken, frozen chicken that for delivery. So someone donated to us a big van. Tapos that we converted into a morgue. So doon namin eventually linagay yung mga bodies ng patient. So it's one good thing, no, na meron tayong ganun, kasi it's very difficult na i-handle yung mga um, disease body, yung mga bodies ng mga patient, and um, lalo na magkakalat pa siya ng mga infection. Okay, let's go to the next slide. Okay, so let's discuss about incident command system. So ICS has evolved to an incident management system for all hazard and can be used in small or large scale incidents. For the case of the pandemic, COVID-19, of course, it's a large scale incident. It's not just a hospital based na command system, but a national, or not even a regional, but a national approach in handling the COVID-19. Okay. And ICS is designed to be usable for managing all routine or planned events or any size, or for any size or type. Allow personnel from different agencies or departments to be integrated into a common structure that can effectively address issues and delegate responsibility. So the reason why we want to standardize the incident command system, because we want a unified approach. Okay, so a standardized approach to the command, control, and coordination. So whoever is inside the incident command system, they're speaking on the same language. Okay, so that's why we need to standardize this incident command system. Okay, so under Department of Health, we have our own incident command system, and we speak our own language, so that we are also sharing with the other health facilities. So pag sinabi natin code white, everyone will understand what code white is, or code black or code red. Everyone would understand what code black or code red is. Okay. Okay, let's go to the next slide, the Hospital Incident Command Team. Okay, so the HICS, or the Hospital Incident Command System structure, is an ICS structure, or Incident Command structure, specifically designed for hospital. The principles presented in the HICS framework overlap the mission of areas. So, diba, no, medyo nag-overlap siya with the prevention, protection, mitigation, response, and recovery that we discussed a while ago. The HICS can be used in both emergent incidents and non-emergent events, and the function are performed by the Hospital Incident Command Team. So we have the structure, the Hospital Incident Command System, and the team who operates the HICS is the Hospital Incident Command Team. Okay, so as you can see, we have the command staff here in the slide presented. So we have the hospital incident commander. So this is the administrator in charge, or they may delegate it to another high official inside the hospital. And then down the line, we have in the command staff of your HICT or HICT, you have your public information officer, which provides official information to the media, so that all information will be centralized. You also have your liaison officer that connects the external agencies in response effort, because of course, you need to network, you need to coordinate with other agencies, so that you can be provided with with augmentation or with help. So like for example, at East Avenue Medical Center, we have a liaison officer that coordinates with Department of Health, or with the LGUs, local government. So for in our case, it's Quezon City. So siya lang yung nakikipag-usap dun sa agency na yun or sa office na yun, so that augmentation or anything that we need, siya yung naglalayas. Okay? And then we have the safety officer. This person identifies hospital threat and takes steps to ensure continued safety of the facility, employees, and patient. So a hospital is very big. So yung safety officer is not just one. We divided it per team or per area. Okay. So for example, at the emergency department, we have safety officer for the nurses, and we also have nurses and admin clerks namin, and we also have safety officer for the doctors. Okay. Next would be the medical or technical specialist, or in the case of COVID-19, ito yung mga infectious disease specialists, because they know better how to approach COVID-19 or the pandemic. Next slide. Right here, we can see the operation side naman ng Hospital Incident Command Center. Again, we have the incident commander, and with that person is your BIO, the liaison officer, your safety officer, and your specialist. So down the line, who is really operating on the ground are your operation section chief. You also have your planning section chief, logistics section chief, and finance or administrative section chief. Okay, but sometimes when you do your hospital incident command team, or when you do your structure of your HIC, sometimes nagdudual role yung mga for example, planning and administrative and finance, sometimes dual role sila. But if you can have a point person or a focal person for each section, that would be better, so that they can focus on their work. Okay, so let's go to the operations. Let's go to the next slide. So this one is the usual textbook style na makikita nyo kung how the structure of the operation side of a hospital branch, pwede natin siyang i-remove. Okay. So as you can see in the operation chief, so yun yung head natin in the operation. So they organize and direct essential activities given by the command team or incident commander, and facilitate proper hospital staffing. So inside your hospital incident command, I mean the operations, you have your staging manager, your medical care branch, infrastructure, or you can also have a hazmat, security branch, and business continuity branch, and patient family assistance branch. This patient family assistance branch is very important, especially when dealing mga dead bodies, and also dealing with critical patients. Okay. Now let's go to the next slide, which is the planning section. So the planning section chief develops action plan for operation sustainment in 4, 8, 24, or even 48 hours increments after the disaster. So in our case at East Avenue Medical Center, every day we have a briefing on how to approach COVID, and we adjust our plans. So every day, every morning, nagbibigay tayo ng briefing to all our staff, and then put out the plans and give it to the operations, and let the operations head do or strategize on how he or she will approach it. Okay, so inside the planning section, you have your resource unit leader, your situation unit leader, the documentation unit leader, and the mobilization unit leader. Okay, next slide. The next slide would include the logistics section. So it direct maintenance and supply operation to ensure patient care, supplies, equipment, and utilities for essential hospital function. Ito yung medyo mahirap na work, no? The logistic part, especially during pandemic. The logistics section should make sure that all the needs of the operations is being given. So in our case, in pandemic, during the start, ang hirap ng mga PPEs or even the equipment. So minsan we lack oxygen. Remember, no, na even it was even in the news, no, na we lack supply of oxygen, or even oxygen tank, or even ventilators, kulang-kulang. So again, ito ang importance na having a liaison officer, no? They can coordinate with other agencies so that resources can also be shared. Okay, so inside the logistic section, we have the service branch and also the support branch. Going to the last section, let's move on to the next slide, is the finance section. Next slide, please. Okay, so the finance and administrative section. So these track expenditure of repayment and special purchases. So we have here our time unit leader. Of course, we need to track all our staff kung overwork na ba sila, no? And procurement unit, compensation claims unit, and cost unit leader. Okay, so these compose the financial and administrative section chief. Okay, let's go to the next slide. Now, what are the challenges during the pandemic that we encounter in East Avenue Medical Center? First, we have resources, of course, human and non-human resources. For the human resources, there are doctors, there were nurses that resigned. Totoo yung mga nasa news natin, no, madaming hindi pumasok, or even the support team or support offices, madami ding nag-resign because they were afraid of COVID-19. They may get the virus and eventually bring them back to their home and mahawa nila yung mga kamag-anak nila. So they decided just to stay at home. So that's one problem. Or if hindi naman nag-resign, some of them caught the virus, so hindi sila pwedeng mag-duty. So that's one problem. Kaya tayo nagkaroon ng augmentation, no? Remember, there were augmentation coming from the fire department, the police department, and even the military department, no? They augmented their medical staff inside the hospitals. Okay, so some of the non-human resources na challenges natin, of course, the PPEs, yung food and water natin, or even the electricity, no, yung because we need to reinvent the structure of the hospital. Finances, of course, very masyadong magastos ang COVID-19. Sometimes the hospital can no longer sustain the operation because kulang na yung money, or hindi pa na-reimburse sa PhilHealth, or hindi nakakabayad yung patient. So those are some of the challenges. Administrative wise, it's hard to look for resources, finances, and or even the people itself in the administrative, they were affected by COVID-19. Of course, the operations, no, we need to change the operation plan because of the recent discoveries or recent findings of COVID-19 on how to approach it. Okay. And lastly, who should take the lead during the pandemic? Of course, it's a big emergency or a big disaster, no? So the national government should take the lead. That's why we came up with the National Task Force Against COVID-19. That's why there's an established IATF, the IATF, na Interagency Task Force Against COVID-19. So this is specifically made for COVID-19 on how to lead us or give us direction on how to respond to COVID-19. Okay? So yun ang yun ang purpose ni IATF, to give the guidelines, while the NTF, the National Task Force, they are the operation side. Okay? Based on the guidelines set by IATF. Okay. Now let's move to the next slide. Okay. Now, I'm done with the hospital incident command system. And let me just share to you the National Patient Navigation and Referral Center. So this is in response to COVID-19 pandemic. So we started as the One Hospital Command Center. Now we are known as the National Patient Navigation and Referral Center, or NPNRC. That was established or launched in August 6, 2020 under the Department Order 2020-0653 to facilitate coordination between health facilities and healthcare provider network. As you can see, di ba, sabi ko, IATF will give the guidelines, NTF is more on the operation side, and also the logistic and the other side of the other side of the incident command system. So the One Hospital Command Center is focusing more on the coordination between health facilities, um, be it a patient or any medical or health related cases. So whenever a hospital has a problem or needs coordination, they throw it to the One Hospital Command Center. Okay, so that's how the NPNRC or OHCC works. Okay, next slide. Okay, the Department of Health created the OHCC last July 15. So we soft launched at July 15, 2020 to streamline the referral and transfer of COVID-19 cases and to optimize the use of medical care services at a national level for a unified and integrated COVID-19 response, because we want all the commands, all the resources to be integrated in one, and then there are shared resources. Okay, OHCC serve as a way to ensure that patients are navigated properly to appropriate facilities and prevent congestion of hospital. Because we see in the OHCC how congested the hospitals are, or where are the vacancy, or where are the vacant beds or ICU beds are. That's why we need to navigate properly or refer properly the patient so that they will not get lost, or they will be accepted immediately when they go to the hospital. Next slide. So this slide will show you the flow of the main operation of the NPNRC. So we have our call takers. So the call takers receiving incoming calls from the different hotline, and they will be the call takers will extract information from the callers and will be triaged according to the needs of the caller of the appropriate priority level. So when you call the hotline, we will be getting information so that we can triage and prioritize according to the request. So there are clear set of protocol guides the call takers regarding data collection from the callers. The OHCC would provide different platforms on how the patient can reach us through the following lines. So we have the COVID-19 hotline, which is 1555, and then we are option 2. And then we also have the Pure for Citizen mobile application. So it's downloadable in both iOS and what do you call the other one, in Play Store. And then the our smart and globe numbers. So the call takers will then create an event after getting all those pertinent information. We will create an event regarding the call. Then the event will be managed by the coordinators and do the necessary action. So if the request is for isolation, then we coordinate it to an isolation facility where there are available beds. Or if they need an ICU, we coordinate to a hospital that has a vacant ICU bed. Next slide. Okay. So these are some of the challenges and hurdles. So OHCC was first house. We were first house at the MMDA Sports Center, composed of only 7 employees. So just to think of it, 7 people handling COVID cases nationwide. So sobrang konti, no? And few equipments to start the operation. Aside from the difficulty in referring patient to hospital and large volume of calls being received, the lack of manpower, equipment, conducive workspace, ICT system, and infrastructure, and establish partnership with organization were some of the notable struggles encountered when the command center was starting. So just imagine a covered basketball court. Doon kami nag-start with only 7 people. And then with the vision of expanding, of course, the services and expanding the manpower. That's why we started with a pretty big area with only 7 people. Next slide. So to cope up with the demands, the One Hospital Command Center hired additional staff, improved the ICT structure and system, and conducted strategic planning and workshop to develop different approaches and guidelines in handling cases. Again, even during the response of pandemic o kasagsagan ng ating mga cases, we are still doing strategic planning so that we will know the best approach on handling this much number of cases and where to bring them. Okay, next slide. Okay. Since the number of calls being received by the NPNRC has dramatically increased and can no longer be efficiently handled by basic direct telephone lines, the procurement of a IPPBX managed services offering IP-based technology which can handle multiple and voluminous calls, transition from a basic system network to a more sophisticated PBX with call accounting and recording. So that's how fast that we transition, no, from a very basic to a more sophisticated na ICT structure. It's not the best thing. I mean, it's not the best that we can have, but at least we improve on the ICT structure because the communication line in the ICT system is really very vital um, in the response. Remember, no, yung sa 6 key elements natin, communication is one of the things na importante sa atin. Okay? Next slide. To take it further, the NPNRC plan to acquire an application, an API, to do an API that will enable to send requests to different institutions. So right now, we are just manually calling the hospital, but eventually we will transition to a more sophisticated type or more advanced referral so that we will no longer do a manual calling to the hospitals or to any health facilities. This is specifically to teleradiology, e-laboratory, and e-pharmacy, and also teleconsultation. Also, this plans to tap financial assistance that being offered by the Malasakit Center to help our indigent patients. So, inside NPNRC, we receive a lot of calls, we receive a lot of requests, including financial needs. I could still remember, no, meron kaming request na ayaw daw ilabas ng hospital yung kanyang body. But our mantra in OHCC or NPNRC, we don't tell the client, we don't tell the caller na hindi namin kayang i-handle the case. What we tell is we will look at the right facility so that we can coordinate with you para hindi sila maging lost, no? Next slide. So these are some of the NPNRC system and capacity. So right now, we already have all regions already established their own regional patient navigation and referral units. And we also have generation of reports for evidence-based and data-driven management of operations and recommendations. Using the DOH data collect dashboard and protocols, the navigators will already identify the proper health facility where the case will be referred because we can see where the vacant beds are or where the congested emergency departments are. Okay. Once identified, the navigator will call the receiving facility and properly endorse the patient while monitoring the status of the patient. We only close the events once the patient is already accepted in the facility. Okay. The OHCC module, aside from the data collect dashboard, we also have the OHCC module that has gone various upgrade consistent with the emerging needs of the pandemic. So this dashboard is more on the operations side. We are currently at version 8. This provide information on health facility with, again, with bed vacancies, incubator, and even incubator vacancies in emergency department pending admission, so that we'll know if the emergency department is congested and not. And right now, we are not only responding to COVID-19, but we are also responding to non-COVID patients. That's why we are also monitoring the beds and equipments of non-COVID. Okay. Next slide. Okay. Also, as part of the NPNRC's initiative to improve access of patients to dialysis services, and due to increasing number of clients requesting for hemodialysis center, we had series of consultation with freestanding dialysis clinic were done and led to the creation of the hemodialysis module. So we are also in coordination with the Philippine Society of Nephrology on how the best approach for navigating and referring dialysis requiring patient. Next slide. Okay. The NPNRC is tasked not only with strategic coordination and referral of patients to different hospitals and facilities across the country, but also with the consultation at the comfort of every Filipino home with telemedicine. So we also offer telemedicine, which allows patient and physician to communicate in a real-time conversation in partnership with the OH retained hospitals. So family medicine and emergency medicine residents are currently rotating to NPNRC to do teleconsultation to our callers. Next slide. The NPNRC paved the way for accessible healthcare services to the public and serve as a bridge to address the fragmented healthcare system in the Philippines in line with the Universal Healthcare Law. This is a much needed intervention since the series can be accessed for free at the comfort of every home, regardless of the patient location. So nationwide, the service is available. It also supports the healthcare implementers through provision of holistic healthcare services in all aspects of health, including promotive, preventive, curative, rehabilitative, and palliative pre-hospital care. Hence, the implementation of the NPNRS to regional counterparts for an integrated and systemic approach of patient navigation and referral across the country. Next slide. In support, the DOH released the Department Order 2022-0210, or the Guidelines for the Strengthening of the National Patient Navigation and Referral System, or the NPNRS, in which the OHCS should be strengthened and redefined as it transition to become NPNRS, along with the reinforcement and expansion of the regional counterpart under the supervision of the Center for Health Development, or CHD. The strengthening of this NPNRS shall ensure that all interventions provided are consistent with the goal of the universal healthcare by maximizing the provision of specific and targeted healthcare intervention that is accessible and equitable through an efficient system in partnership with the healthcare provider network at the local level. Next slide. Just sharing to you what the future of the NPNRC would look like. So we are envisioning to have a state-of-the-art ICT capacity that can integrate to all existing health system, meaning to say even the pharmacy, the barangay health center, or the small clinics will be integrated in one system. A triage and EMR accessible to all health facilities within the network, and a telehealth service that can provide general and specific medical service to the public. Next slide. NPNRC hopes to accommodate all calls coming from the community, health facilities, LGUs, and other resources. That is why we aim to have a centralized, accessible one hotline number. So this one hotline number will be easy to use and understand regardless of the educational attainment and age. We already have the approval of the NTC. We're just waiting for a toll-free order where we can already launch the number. Okay, the NPNRC is also acquiring a cloud storage and physical storage that will provide bigger memory for our EMR. So our target is because of the shared responsibility and accountabilities among members of the health system. So again, we're not just dealing with hospitals, but we're also dealing with pre-hospital providers. We're also dealing with standalone clinics and even dialysis center or even diagnostic center. Um, for the delivery of the effective navigation and referral, we are envisioning to have this one patient, one data, one system. So that's our goal, to have the one patient, one data, and one system. So the assignment of the dedicated local number is to interlink the DOH retained hospital and health facilities, and between the NPNRC and RPNRU for a systematic and streamlined patient navigation and referral. Okay. Going to the last slide. So these are some of the key recommendations that we are proposing with our experience in response to COVID-19. So in support to the implementation of the UHC Act, the NPNRS is anchored on the service delivery design of the HCPN utilizing integrated local health system. At the regional level, the roles and responsibility of NPNRC were adapted by some of the existing RP regional emergency operation under the Center for Health Development or CHD. Currently, the NPNRC continues to improve its access to public through establishment of its regional counterparts and referral units inside the health facilities. And lastly, the strengthening of patient navigation and referral centers shall be realized through the following. First, policy development to address the emerging issues and concern in the system to pave the way, the direction in achieving the division of the NPNRC. Second is linkages and collaboration with partners and stakeholders. And lastly, technical assistance among its implementation arm in the regions or the RPNRUs and members of the healthcare provider network in navigation and referral and data analysis and the ideal ICT system framework. So those are the key recommendations that we are proposing because of our experience with handling the pandemic. With that, I'll be ending my talk on the hospital incident command system and introduction of the national patient navigation and referral system. So thank you for listening, and I'll be opening the floor for any question or clarification that you may want. Thank you.
Thank you, Dr. Velasco, for that discussion. PIC's a bit complex, but an interesting system that allows for maximum capacity of the hospitals. Before we proceed to our open forum, I would like to ask everyone, how are you feeling now? Are you still awake? Let us know your current mood by reacting or sending emojis to the chat box. I can see that there are those who are I can see that there are those who are sending heart emojis. Looks like everyone is still alive, alert, awake, and enthusiastic. Let us proceed to our open forum. We would like to request Dr. Velasco to be back to the virtual stage.
If anyone has any questions, our speaker would be pleased to answer them. You may click the raise hand button or either type your questions in the chat box. So Doc, we have our first question here. This is a question from an anonymous sender from CPU College of Nursing. How will you be notified if there is a hospital incident command system during a disaster? Again, how will you be notified if there is a hospital incident command system during a disaster?
Um, Probably I need to confirm yung context ng question, no? So how would I be notified? Yung I is who am I? Am I a staff inside the hospital, or are you asking me as the operations manager of the NPNRC? But if you're
If
asking,
you are the staff, doc.
okay, so there should be an established communication or guidelines on how to activate or start an incident command system. Let me just share you what we are currently doing at East Avenue Medical Center. So whenever there is an incident outside, and then there's a report that they'll be bringing in patient inside the hospital, let's say one bus or two buses of um, cases or injured patient that will be brought inside the emergency department, it is only the emergency room officer who can activate the ICS. Okay? The activation process would be confirmation of the report. Once confirmed, the emergency room officer or ERO will inform the senior house officer and also the admin officer on duty. If in case it's an office hours, it will be the chairman of the emergency department and the head of the admin officer and the medical center chief who will activate the HICS. Okay? So that's the process of activating it. Now, going down the line, once the decision of activating the HICS, then we have a code inside the hospital. So may alarm siya that we are already activating the incident command system. Like for example, we can do an alarm, or we can make use of the paging system that we are currently activating, and all people assigned kailangan bumaba sila sa emergency department. So what we usually do is that um in our tour of duty, alam na natin kung sino yung magiging officer. So, sino na si operation chief, sino si logistic chief, sino si finance chief during the tour of duty, regardless if there would be tawag dito, there would be an incident or not. So that pag nag-activate, alam na ni yung assigned na operation chief that he or she will act as an operation chief. I hope I answered the question. Thank you.
Hello, Doc. Another question from Cleo Daradar. Doc, you have given us an idea of telemedicine. In telemedicine here in the Philippines, does nurses have a role?
Of course, the nurses have a big role in telemedicine. When you do telemedicine, it's not only consultation, no? Madami tayong mga programs. You're studying about TB program, diabetes program, cancer program, no? It's not only consultation that we encounter during telemedicine, but just asking what are the things that we can do, or what are the things that we need to do, or ano yung dapat hindi natin gawin. These are things na kayang sagutin ng mga natin, no, ng mga nurses natin. And sometimes yung mga usual na mga medical advice, you can also give that to our callers. So not necessarily a doctor should be talking to the patient, but also pwede din yung mga healthcare workers, particularly the nurses, or even the mga nag-handle ng mga programs natin sa Department of Health. They are not actually doctors, but they are giving advices to the patient what to do, where to do, and where to get the medicine and how to take the medicine. So these are things na collaborative lagi yan, no? It's not only the doctors who will act, but also the rest of the healthcare providers who will be helping in doing the telemedicine. Thank you.
Okay, Doc, we have another question from Linda Sujoso. Good morning, Doc Velasco. As we prepare for the transition phase of this pandemic to endemic status, what are your suggestions to DOH in response to better implementation of OCHH or NPNRC? Is it a good thing that DOH retained hospitals in NCR has an active OPCEN for easier referral of patients from one institution to another? Hope we can have that here in Region 6 too. Thank you.
Yeah, actually, we have a very active regional OHCC at Region 6. So, baka hindi pa lang masyado na nakikita or nakikilala yung number nila. But since this is national, what I am currently handling is national, we will be able to coordinate cases regardless of the location. So if you're from Region 6, you can also dial our number and talk to our call to our um, to our navigators, and they will coordinate with the proper agency. If you're from Region 6, we can coordinate with Region 6 OPSEN, or we may directly go to the hospital. It is the goal of the NPNRC to have a command center for each hospital, so that whenever we have problems inside the hospital, that will be the it will be that command center who has all the data. And kunyari si medical center chief or the medical director wants information on how many stocks do we have in the pharmacy, or how many beds do we the available beds inside the ICU. It will be the command center who will be answering it. So we don't need to call the ICU to ask for the available beds. We don't need to call the pharmacy to ask for availability or the stocks of your supply inside the hospital. So to answer, no, what are your suggestion to DOH in response to better implementation of OHCC? Again, the communication line is very important. ICT structures is really very important, but we all know the limitation of our internet, our connectivity. That's why it's not only DOH who will be acting on this, but also the other agencies as well. It's not only DOH that we are targeting, but also the LGU owned hospitals, and also the private facilities as well. That's why it's really a big goal that we are currently achieving, no, or envisioning, to connect all the health facilities, so that everyone will be integrated in one system. Um, we're not saying that they need to use our own the current system that we are using, but just a permission that whatever system that they are currently using, they can link it to our system using an API, or a bridge from one system to another system. Thank you.
We have another question here, Doc. Good morning. Does this emergency response system, or HICS, being uniformly followed by all hospitals, including the private hospital, in all regions of the hospital? Will your agency be issuing a manual as a guide to those hospitals?
So for the ICS, there's a specific course for the hospital incident command system. So but it's not under Department of Health, but I think it's under ASEAN. I forgot the ano, I just forgot the certifying body, but it's not under DOH. Although in the DOH, under the Health Emergency Management Bureau, we have this course na mass casualty management. It's pretty much the same of what ICS is, but focusing more on health related incident. And also under OCD, we have the ICS course. So this is the course na most of our executive are going through. So most of our medical directors, and even the LGUs, ito yung course nila, yung ICS. So it's under OCD, Office of Civil Defense. So if you want a unified, a unified approach, we have to be knowledgeable on the ICS. So sometimes if you just read the books, no, if you just read the books, it's all the same. Um, it's a matter of how you share it, or how you lecture it, or how you provide the course. Pero pretty much it's an open book yung ICS natin. Thank you.
Thank you, Doc, for that response. We also have another question here. You said that in the first few months of the pandemic, our country was not prepared to respond. Do you think we now have the means or have detailed plans in addressing this pandemic?
So right now, admittedly, nobody was prepared in the pandemic, but because of our experiences and new discoveries and new researches about COVID-19, we have a better approach. No, so before we isolate everyone inside an isolation facility. But because of the changes even the virus, no, yung clinical presentation niya, we can already have a we can already allow a patient to isolate at home, as long as makuha niya yung minimum standard, no, ma-meet niya yung minimum standard inside the house. But yeah, for now, with the number of cases, I think we're handling the pandemic quite well. And there's a lot of improvement because of the things that we discovered during the pandemic. It's not a perfect system, it's not a perfect approach that we are currently doing, but I think it's the best one that we have. The approach that we are currently implementing is the best thing that we already have.
Another question here, Doc. How can you improve emergency response in rural areas or those areas that are difficult to access?
Okay. So these are things, no, because of not the equity of the health services in our country, no. So in the rural areas, medyo mahirap madala sa mga level 3 or even level 2 hospitals. That's why we need to capacitate the healthcare provider in that area, training them, giving them the best approach on how to handle such cases. So it doesn't mean that we have to establish immediately a hospital near that area, but just capacitating the people inside, the healthcare providers or frontliners in that area give will help a lot. So I think yun yung best approach natin, to capacitate the people inside that inside those areas, dun sa rural areas natin. And then eventually, if hindi na talaga kaya and advanced care is needed, then that's the only time that we will transfer. But at least we have given the basic or resuscitative measure to that patient while traveling the patient to the appropriate or definitive facility or definitive hospital.
So due to time constraints, we will only entertain two more questions. This one is from Mark Pogata. Good morning, Doc. How challenging was patient load balancing during the height of the pandemic, and are there still challenges today?
Yeah, there are still challenges today, as mentioned. Now, we're not only dealing now with COVID patient, but we are also dealing with non-COVID patient because of the 2 years delay of no consultation or not even updating their medicine. So right now, we're dealing with a lot of hypertension, uncontrolled diabetes, or even yung delayed chemotherapy to the patient, to a cancer patient. So that's what we're currently dealing now. So it's quite a balancing of how to allocate resources for COVID and non-COVID COVID and non-COVID cases. But eventually we need to live with COVID. So hindi na pwede na we have a whole building for COVID, but we'll have a part of the building specifically for infectious diseases. Okay, so not only for COVID, but for infectious diseases. So that's how we are approaching it now. So there is a guidelines from the OH wherein we're transitioning to endemic phase. So what is written in the guideline is that for every region or for every key city there will be a COVID referral hospital, and the rest will just maintain a lower percentage of allocation to COVID-19 so that we can accommodate more non-COVID patient. But if we see an increase in the number of cases, then the facilities will need to adjust and allocating 20% and 30% again. So it will be a parang transition into the response phase again. Kasi ngayon, we're in the transition phase. So meron na lang mga COVID-19 referral hospitals, and then some of them are just maintaining a few beds for COVID-19. But if there's an increase in the number of cases, then all the health facilities should again maintain a 20 to 50% of their bed allocation to COVID-19.
And for the last question, Doc, from Michael Angelo Gamisera, in telemedicine, what are the qualifications needed? Are there any certifications we need to acquire first before we join the team?
Okay, right now for telemedicine, there's no quite clear guidelines on how to be accredited in the telemedicine. So it will be part of the facility kasi. So if you're part of a facility or an institution, it will depend on the services that you will give. If you have services like specifically or strictly for teleconsultation only, then it will be the doctors who will only be doing the teleconsultation. But if you also have services like giving advices, then other healthcare workers can be involved in the telemedicine services of that institution. So right now there's no guidelines on the licensing and accreditation of telemedicine. None that I know. Thank you.
Thank you, Dr. Velasco, for the answers offered. Our team will also be collating the questions from the chat and will be addressed accordingly to our resource speaker. To extend our gratitude, we are presenting the Certificate of Appreciation to Dr. Velasco.
May we call on our advisor, Mr. Benson Yap, to assist in the giving of the certificate. Dr. Velasco, on virtual stage, please. The certificate reads, Central Philippine University College of Nursing, the first nursing school in the Philippines, 1906. Certificate of Appreciation given to Bernadette E. Velasco, MD,